heart. So good afternoon and welcome to Ask the Experts, a conversation hosted by SCAD Alliance. I'm Rebecca Freeman and I'll be moderating and leading our conversation today. I'm a board member of SCAD Alliance and two-time SCAD survivor. If you're new to SCAD Alliance, we're a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of SCAD. So in addition to our independent multi-center iSCAD registry, one of our main goals is to support patients and families. And so as part of that, we've developed this monthly webinar series called Ask the Experts. We're hoping to offer support and education to survivors and caregivers by engaging in conversations on SCAD-related topics each month. So be sure to check out our past webinars on topics including PTSD, exercise, genetics, FMD. So today we're talking about hormones and women's reproductive health. So hormones across the lifespan are key interests for SCAD Alliance. We'll discuss what we know about hormones in SCAD, as well as what that means for contraception, pregnancy, menopause. And so while some of these topics may not apply to every single person who's been impacted by SCAD, we're also really excited to highlight 3 of our iSCAD sites and see what great centers with robust multidisciplinary women's heart programs can look like. These doctors are focused on treating the whole woman. The heart's not just in isolation. So another thing, and the disclaimer I start with every webinar is especially important today. While lots of progress has been made in SCAD research, we do not yet have huge data sets to make firm recommendations that apply to every single patient. Okay, so the information presented today is based on the extensive expertise and experience of these physicians, but it may not be 100% the answer for every individual. So it's really important for each of us to talk to our own medical team to make specific plans for your care. Research is coming. Our iSCAD registry currently has 17 sites across the country, over 550 patients enrolled. And it's really, really exciting as the more people who enroll, the more we're able to have these large cohorts, and publishing solid data. Dr. Naderi will touch on this a little bit at the end too, but just wanted to give that disclaimer as always. So with that, I want to introduce our panelists and get right into our discussion. So Dr. Sahar Naderi, welcome. Dr. Naderi is a cardiologist and director of women's heart health at Kaiser Permanente, San Francisco. Dr. Naderi has expertise in conditions that disproportionately impact women, specifically SCAD, as well as in aortic diseases like Marfan syndrome. Dr. Naderi is a SCAD Alliance scientific advisor, as well as member of the iSCAD Registry Steering Committee and Principal Investigator of our iSCAD site at Kaiser San Francisco. So welcome to you. Dr. Catherine Lindley is a cardiologist, associate professor of medicine, director of the Women's Heart Disease Center at Washington University, St. Louis, and Missouri. Her research interests include women's heart disease in pregnancy, peripartum cardiomyopathy, contraception in women with heart disease, and the cardiovascular sequelae of preeclampsia. She's principal investigator of the iSCAD site at WashU. So welcome, we're really excited to have you. Dr. Kathy Economy is assistant professor of obstetrics and gynecology at Harvard Medical School. Her area of focus includes cardiac disease in pregnancy, high-risk pregnancy, maternal fetal medicine, multiple births, as well as rheumatologic and autoimmune disorders. Thank you for joining us. And Dr. Amy Sarma is a non-invasive cardiologist with particular interest in women's cardiovascular health, cardiovascular disease in pregnancy, and sex differences in cardiovascular disease. And she's a member of the Massachusetts General Hospital iSCAD program team. So welcome to all of you. We're really excited to have this discussion and talk about some of these big questions for people. So we're going to start with you, Dr. Sarma. I believe you have a couple slides. If you can start us out with just an overview of SCAD and appropriate workup and screenings and kind of what comes next, what's first after diagnosis.
Wonderful. Can people see my slides up here? Fantastic. So thank you so much for having me today. This is a wonderful session, and I'm looking forward to the discussion that comes from this. I'm a cardiologist of the Massachusetts General Hospital, and I'm part of the Women's Heart Health program here, and have a particular interest in SCAD as well as cardiovascular disease in pregnancy. So I just thought I would show a couple slides to give us a little bit of an introduction to this topic. So why do we think there's a potential relationship between hormones and SCAD? So the first clue that we get is just from epidemiology, and there's a significant female predominance of SCAD, so much more common in women as compared to men. And these are all sort of registry data that suggest 87 to 95% of SCAD events occur in women. So the average age is not necessarily among women just who are undergoing pregnancy, even though oftentimes that's the association that women may come into this with. But with that being said, a higher proportion of heart attacks that occur among younger women tend to be spontaneous dissections as compared to traditional atherosclerotic heart attacks. And in particular, women who experience heart attacks around the time of pregnancy, or among those heart attacks, a higher proportion are spontaneous dissections as compared to heart attacks that occur in other settings. I really like the schematic showing that there are multiple factors that play into spontaneous dissections. And as you can see here, sex hormones are thought to contribute, given these observations here. So just to review very briefly, there are a couple of different theories out there about exactly what happens during a spontaneous dissection. But in essence, the reason why women have heart attacks in the setting of spontaneous dissections is because if this is your blood vessel and this is where blood typically goes through in order to supply the heart muscle, either because of a hematoma or a sort of a bruise and bleeding that happens outside of this main tube, or a tear, basically what happens is blood accumulates outside of the vessel that's actually bringing blood to the heart and compresses that, and that results in impairment to blood flow that leads to the heart attack that's associated when spontaneous dissections. Oftentimes. And we do know that there are differences between spontaneous dissections that occur in the context of pregnancy as compared to outside of pregnancy. So this has been a significant interest of ours. And in particular, we know that in the context of pregnancy, women are more likely to have what are called ST segment elevation myocardial infarction. So this is a particular trigger for cardiologists, meaning a more acute sometimes heart attack in terms of the way we think about urgency of getting women to the cath lab, that oftentimes women will be more likely to see an impairment in their heart function if they have a spontaneous dissection in the context of pregnancy. And they're more likely to have dissections that involve main blood vessels or multiple blood vessels as compared to those outside of pregnancy. That's why we worry more about these pregnancy-associated dissections. And there are a lot of things we just don't know about this. And so these are, as you can see here, research questions that we have. I will say that I am also on clinical service and just got a page. I don't know if one of the other cardiologists can pick up just for a second, and I will resume if maybe Dr. Lindley wants to take it from there just for a second, and I'll be right back. I apologize.
Certainly. I have not seen Dr. Sarma's slides, but I will do my very best here. So certainly we know that, while a small portion of pregnancy-associated coronary dissections do actually occur during pregnancy, it's actually after the delivery that the majority of those coronary dissections occur. Actually, after delivery, there are a lot of changes in hormone levels. You're actually more likely to form blood clots during that period of time than you are during the pregnancy itself. And there are also a lot of changes in the volume of blood within the blood vessels. And so all of those things may contribute to these to this increased risk of having a coronary dissection after the baby is born. And the majority of these dissections actually occur in that first 1 to 2 weeks after delivery.
That's awesome. And so Dr. Sarma has control of her slides.
Okay.
So, but there's really only one or two others that she has. So talking a little bit about what happens after SCAD diagnosis, as well as kind of the multidisciplinary approach. And so I'm wondering if we can, if you want to jump in a little bit on that, but then also we were going to talk with you about kind of contraception and what does this mean for kind of other typical medications and hormones that impact women's life too.
Absolutely. So after a woman is diagnosed with her SCAD and goes through her initial treatment, most women are going to be placed on some medications. The vast majority of women are going to be placed on a beta blocker medication that includes something like metoprolol, carvedilol, atenolol, propranolol, one of those medications. Many women will also be treated with aspirin, and then some women will be treated with some other medications like other antiplatelet agents such as clopidogrel or Plavix, and some women may also be occasionally treated with medications such as lisinopril, or rarely may even be put on a cholesterol medication. So it's important that patients be treated with the medications that their doctor recommends, with that beta blocker medicine being the most important of all those medications. And since the majority of women who have a SCAD event are actually still going to be in their childbearing years, it's going to be important to then start to think about how that might impact potential future pregnancies, and how can you either plan for or prevent future pregnancies. Now, I'm going to let in a few minutes Dr. Economy talk a lot more about actual pregnancy risk and pregnancy planning, but you're going to want to have a very, careful conversation with both your SCAD expert cardiologist as well as a maternal fetal medicine specialist to think about if proceeding with another pregnancy is going to be right for you. There's a lot we still don't know about this, but what will be important is that you get really careful multidisciplinary care between a specialized cardiologist and an MFM specialist who both have expertise in this condition. And we definitely want to avoid any surprises. So we want to make sure that mom is in her optimal state before moving forward through a pregnancy to help make sure that both mom and baby can have the best possible outcomes. So it's going to be really important to think about birth control options in order to make sure we can help plan those pregnancies. Now, there's still a lot we don't know about what methods of birth control are really optimal for a woman who's had a SCAD event. However, many experts have some of the similar ideas about what maybe are optimal to use for patients with a SCAD event. I think there's two main things that we want to think about. The first is how safe is the method of contraception, and the second is how effective is it? Because we both want something that's going to work well and also something that's going to be safe for mom. Typically, the most effective methods of birth control are going to be those that either are the long-acting reversible method, so that's either the IUD, which can either be have a low dose of a progestin, or it can be a non-hormonal IUD, which is a copper IUD, or else there is something called the subdermal implant, which is like a small plastic rod that goes in the upper arm. And all three of those methods are generally considered to be safe for women who have had a coronary dissection. And they're all very effective as well. They carry a less than 1% chance of becoming pregnant over the course of the year, and they're all reversible. Of course, having your partner have a vasectomy or undergoing a tubal ligation are also very effective. One thing to consider is certainly a tubal ligation is a surgical procedure, which carries a little bit more risk than having one of the reversible methods placed. But for most women, it's typically safe to undergo a procedure such as that. The types of methods that we get a little bit more concerned about are the methods that are hormone containing, that contain estrogen. So that includes things like the combined hormonal pills, the patch, and the vaginal ring. So all three of those methods contain estrogen and are typically associated with a little bit increased risk of forming blood clots. Now, the data regarding those methods in SCAD is not very well identified. There are some reports in the literature of women having SCAD while being on combined hormonal methods of contraception, but of course, lots of women use birth control pills, and so it's hard to know if those are truly related. But that said, in general, the CDC recommends that for women who have had a coronary event, whether that be a traditional type of heart attack, or I would generally consider a SCAD event, that they not be the preferred method of contraception. Now, I think it's generally also important to remember that really pregnancy-related risk is always higher than contraception-related risk. So if the only method of contraception that you're comfortable with is a combined hormonal method, and you've discussed it with your doctor, your team of doctors, I would say that's still preferable than using no method of contraception, in which case you will be at risk for having an unplanned pregnancy. Now, the combined hormonal methods are a little bit less effective. So there's about a 6 to 12% risk of becoming pregnant over the course of the year using those. So that's just another thing to keep in mind. And so sometimes using a barrier method like condoms can be helpful as well. And so if you do decide that you want to move forward with pregnancy, as I mentioned, having a really serious conversation with your cardiologist and your OB, your MFM doctor, such as Dr. Economy, is going to be really important. So I'm going to hand off to her now so she can speak a little bit about what may those risks be and how might we want to think about approaching a pregnancy.
Wonderful. And I do want to keep going through to Dr. Economy. Dr. Sarma will come back to kind of some of that multidisciplinary stuff. I think maybe if you and Dr. Naderi tag team that at the end. So Dr. Economy, you'll kind of take off from there. So, I appreciate that discussion of contraception and what considerations I think is applicable to a lot of people. And so kind of what next? Can a woman become pregnant after SCAD event? Does it matter if their SCAD event was related to pregnancy or not? Can you talk us through?
Sure. Well, Dr. Lindley already took my favorite line, which is that it is always safer to use any contraceptive method than it is to be pregnant. But of course, pregnancy is not always a decision about what is the safest thing, right? So if the question is what is the absolute safest thing? The safest thing certainly would to not carry another pregnancy, would be to not carry another pregnancy. I think that there's enough concern around the hormonal changes, around the increase that we see in SCAD postpartum, that in a woman with a history of SCAD, if they really just want to have the biggest way to have risk reduction, it would certainly be to not attempt a pregnancy. That's not to say that a pregnancy can't be safely accomplished. I'm sure we've all had women with SCAD history who we have safely guided through pregnancy, but it requires a sort of a thoughtful approach that really begins preconceptually. And so in the ideal world, you would meet with your cardiologist, your maternal fetal medicine specialist, and have a very sort of like comprehensive conversation about what the risks are of recurrence and if there's anything that can be done to minimize it. We certainly would want to make sure that you are in the best cardiovascular health prior to starting a pregnancy. I think that anybody who has, as associated with their SCAD has heart failure or has other, knock-on problems, then you would then move probably to a much higher risk than someone who has had a SCAD and completely recovered. It may be that you have a stress test. It may be that we ask for more imaging prior to conceiving a pregnancy. So all of those I's need to be dotted and the T's need to be crossed. If you're somebody with excellent functional status, leading a sort of totally normal life where you can do everything you want to do and exercise if you want to exercise and those things, then I think we can move the conversation forward. We would want to switch any medications that you're on that we don't use in pregnancy. So typically the ARBs and the ACE inhibitors are medications that we would want to take you off of, not just take you off of, but transition you to a different medication well prior to pregnancy. And then there are some little things that the obstetricians always want to remind you that you should be on folic acid at least 3 months before conception, and sort of limit alcohol and caffeine consumption around conception time. During pregnancy, we would recommend staying on a beta blocker. And that's something that comes up a lot because for most women in pregnancy, they'll find that their blood pressure gets lower in the second trimester, and some women become a little intolerant of beta blockade. So we do need to work closely with the cardiologist to try and get you on the lowest dose to which you still feel good. We generally, when women take beta blockers during pregnancy, we generally recommend growth surveillance of the fetus with ultrasound. And then there is delivery planning. And this is an area that always is, has a lot of controversy. And whenever there's a lot of controversy, it's largely because there's no data, right? So if we had perfect data, you'd get the same answer every time. And so this is an area where, again, it involves a lot of shared decision making, I think. There, as you saw from Dr. Sarma's graph, most SCAD occurs postpartum. There are very few, and I would be interested to hear what the panel's experience is of just intrapartum events that we see when a woman is in the act of delivering her baby and has a SCAD. You know, that's something that I would say is an incredibly rare occurrence. And so for my women that I take care of, we have a conversation, particularly for women who've had vaginal deliveries before. I counsel them that we can minimize pain, minimize Valsalva, and the vast majority we guide safely through vaginal delivery. There are recommendations in the literature to perform cesarean delivery for SCAD. It can't be that those are wrong and the other one's right, because we just don't have the numbers to know. But that certainly involves a careful conversation of what are the risks of a cesarean delivery. You know, the excess risk of blood loss, the excess risk of infection, the excess risk of developing blood clots postpartum. So those are all things that we take into consideration when we do our counseling. And then postpartum is the time that I am most carefully watching women, checking in as frequently as possible. Sometimes they stay in the hospital a little bit longer, make sure we get them back on their dose of beta blocker and as tuned up as possible before they go home, with all the precautions and very, very close follow-up. Oftentimes I will counsel them that perhaps they should get their contraception before they leave the hospital. So we do put in IUDs at delivery. They have a slightly greater expulsion rate, but the rate of retention is much better than if you never come back to get it placed at your postpartum visit. So a lot of the women that I take care of actually leave the hospital already with the IUD. I think the other thing, just to tack onto the contraception conversation a tiny bit, is that the numbers, you know, there are the numbers that you read about that are associated with perfect use. And those numbers are very good for all the contraceptive methods. And the problem is really like, are you going to be able to take a pill at the same time every day? Some of them, like the progesterone only containing oral contraceptive pills, are not very forgiving if you miss a day, or, you know, so I think that you have to think about going home with your new baby, like what you're going to be able to really be capable of. And so in those settings, you know, lots of times I think it's much easier and safer to get your contraception in the immediate postpartum period before you leave the hospital. So I think that's sort of in a nutshell.
Wonderful.
Sure, there are more questions, but
yeah, no, absolutely. And that's, you know, I really appreciate highlighting that there's so many factors. And of course, all pregnancy is going to be different for each person, regardless, you know, whether or not you've had a SCAD event, but especially given that. So I really appreciate you being able to talk through all that in terms of getting, you know, what we should talk to, you know, our providers about if somebody's considering pregnancy. I want to go ahead to Dr. Naderi. I do have more questions for you, Dr. Naderi, but I want to kind of segue into, you know, everybody else. You know, there's lots of people, lots of women who have not had pregnancies or are not planning to have pregnancy. And certainly pregnancy is something that, you know, a lot of times we think of when we say women's reproductive health, but guiding through menopause as well and some of these other stages. I want to know if you can touch on that, and then we have a bunch of questions that were submitted in advance. I want to make that way we can get to them.
Sure. So I'll be quick on this topic, mainly because the real answer is we don't know, right? There's been a long-standing decades and decades worth of nursing data that we've kind of gone back and forth about whether hormone therapy is safe, protective, equivocal. And you could kind of sit a bunch of cardiologists and MFMs and gynecologists in a room. We could probably argue all day about this topic, which goes to say that nobody really knows what the right answer is. So what I always tell women is that as your cardiologist, as your women's heart health cardiologist, we try to be a little bit more holistic and kind of look at the overall picture as opposed to just focusing on your heart. But even for us, it's difficult to do, right? We're cardiologists, so your heart is the most important organ and everything else is by the wayside. So I think the most important thing is to have honest, open, frank conversations with your gynecologist and your cardiologist about your quality of life issues and what's being affected when you're going through menopause. Because the argument is also that if you're having horrible menopausal symptoms, that psychological and physical stress also has an impact on your SCAD history as well. So I think just open dialogue about the things that are really impacting your quality of life are important. So that's kind of the first step. And encouraging you to find a cardiologist who's open-minded about kind of the other non-cardiac things you're dealing with. In addition to that, so the general rule I have is that the data suggests that hormone therapy is not protective for any cardiac condition, but potentially is not detrimental to any cardiac condition within the first few years after menopause. So I tend to worry more about my patients who've been on very long-standing hormone therapy beyond that kind of 5-year mark. So there's some data that suggests it's potentially reasonably safe to take hormone therapy within the first 5 years, but then beyond 5 years is when we start to see a signal towards cardiac harm. So some of it actually has to do with how long you're going to take the hormone therapy in addition to the quality of life issues. I think we have fairly firm data that for cardiovascular disease in general, it's not going to be protective or helpful, although we could spend some time arguing whether that's the case or not. I know a lot of my women say, well, if you think menopause is somehow related to my SCAD, then wouldn't it stand to reason that if I start hormone therapy and it kind of balances things out, that should protect me? And the answer is we just don't know. So it's a lot of conversation of risk benefit of a relative unknown, particularly for SCAD patients, which you're a subgroup that's different from our atherosclerotic or plaque-related heart attacks. So I think it's a gray zone that just requires a multidisciplinary conversation, just like determining whether you want to pursue another pregnancy after a SCAD event. We were talking offline before everyone joined about the vaginal estrogen issue. I get this so much that I just feel like I need to bring it up. So I think we all agree that the data is not very clear on how much systemic absorption there is. Clearly it's less than a pill, but it's not no systemic absorption. And Dr. Economy was pointing out that perhaps, you know, someone who uses vaginal estrogen daily versus someone who uses it every couple of weeks, perhaps there's a risk differential there too. So I just want to encourage folks. A lot of my patients say, well, I'm just using vaginal estrogen. And, you know, again, it's risk benefit quality of life. But those that are using that formulation too should have conversations with their cardiologist. It's just not necessarily something that I don't want to generalize, but outside of women's heart health, your cardiologist may bring up with you spontaneously or even note in your medication list. So I think the most important thing is just open dialogue and conversation.
That makes sense. And that seems like definitely a common theme across this discussion is that risk benefit discussion and being able to have a provider that you can talk about that with and kind of figure out what is the best case to optimize these things. I want to jump into a bunch of questions because we got a bunch in advance. This has been really helpful. Dr. Naderi, while we're on this, can I go ahead and ask you, are there any specific hormone replacement products that are considered safe, you know, quote, natural products or anything like that? Is there anything that we know or you can say definitively is Good
Yeah,
to go?
I think I usually punt this question to my MFM and gynecology colleagues. So I'm gonna throw past the ball to Dr. Economy. I think my general feeling about you know, kind of holistic strategies is because the FDA doesn't regulate any of these formulations. I'm not sure anyone can give you a good answer on alternative therapies, but I know there are a few that those in the OB world do recommend. So I'm gonna punt to Kathy and see what she has to say about this.
Well, I am a maternal fetal medicine specialist, so I will say that my life cycle sort of ends with pregnancy and the postpartum period. But I actually think it's important, and there are physicians who make their whole career around this topic, and so I don't want to infringe on that area. I do think it's important to recognize what Dr. Naderi said, which is that you have to be careful when you buy black cohash over the counter or these phyto soy estrogen products. They're totally unregulated. And some of them may be much higher actually than what you might take in a low dose pill or like a vaginal estrogen preparation. I think it's important to stay in the lane of these aren't protective for your heart, any of these estrogens across the range. I think we sort of know that. So really it's just for symptom modification. And in that case, there may be other types of medications and things that may work as well, different types of patches. I would say anything that is vaginally or even transdermally absorbed is going to be probably a bit less than, in its lowest dose, less than the oral absorption. So it's important to focus on, what are the symptoms that are bothering the most? Is it that you can't sleep at night because you're having night sweats? In which case, maybe approaching that problem differently than you would, vaginal dryness or a discharge that is unpleasant to you. So I think really, actually, it's pretty honed down. No one should be just taking general estrogen replacement therapy, I think, who has a history of SCAD. I think that's probably the wrong approach. It's much better to really be focused. And then contraception, like I said, we do that every day. And I think Dr. Lindley really covered that nicely. Just to reemphasize, we would always start with the non-hormonal things. And so, the copper IUD is a good choice. And then among the hormonal related contraception, really, I think the ones that have the best patient satisfaction profiles are either the ones that are the subdermal implants, which can last from 3 to 5 years, or the progesterone, one of the different types of progesterone containing IUDs. And actually now they probably have 3 or 4 additional IUDs on the market that are different sizes, contain different doses of progesterone. So even lowering that progesterone dose further. The things that people are a little less tolerant of or have, I think, more side effects, like the Depo-Provera, which is a monthly shot. A lot of women experience hair loss to that and weight gain. So that, again, better than nothing. But when I have these conversations, it really then becomes more like, well, what is your lifestyle, right? What is the thing that you're going to be most adherent to? And some women are great at taking a pill every day. And so for them, taking a progesterone only pill might be just fine. None of the contraceptives, also important to point out, that we're talking about prevent against sexually transmitted infections. And so the only way to protect against those is to use condoms, right? So no matter what, I think, remember that there's like a much larger scope of things that we're trying to keep you healthy. Ways that we're trying to keep you healthy. And then the CDC, I think, has a very helpful spreadsheet once you kind of get into it, their medical eligibility criteria. You can just Google that, and it lists all the medical conditions down one side and the contraceptives, different types of contraceptives across the top. And just in a very graphic fashion, you can kind of see it goes from like green to red in terms of what kind of contraceptives are recommended in different cardiovascular risk settings, in all kinds of settings, actually. So that's something that we often refer to. And I know I've gotten all our cardiologists hooked on it.
No, it's wonderful. It's a great tool. And I think it's a good reminder too, that there are lots of options. I think, sometimes we're in a space where, when I think of pregnancy prevention, the first thing that comes to mind is the pill, and remembering that there are lots of options for both contraception as well as for treatment of symptoms, in menopause and treatment of whatever you need across that lifespan.
And I think one thing Dr. Economy mentioned, so almost every institution has gynecologists who specialize in the menopausal, perimenopausal period. So I would encourage those who are listening who have questions about getting down to the nitty gritty of hormone therapy and alternatives to hormone therapy to reach out to folks who have a special niche or interest in menopause, because they're probably your greatest resource. I think we, as women's heart health specialists have a reasonable understanding of these things, but are certainly not experts when it comes to, what should be taken if that's pursued. So I'd encourage you guys to do your research and find somebody who can really hone in on those questions for you.
And the same is true actually of family planning. I would say most of the centers that do SCAD work probably also have family planning specialists that can help with figuring out what the best agent is for you. There is a question in the chat. Do you want me to address that now or at the end?
Dr. Lindley,
Okay.
Did you want to add on to that?
I was just going to also add, I agree with everything that Dr. Economy and Dr. Naderi have said about all of the above. But I was also just going to add, there are also some non-hormonal prescription medication options for treatment of some of the menopausal symptoms. They're not quite as effective as hormones are, but for some women, it can really get them relief. So for example, there's actually an antidepressant agent, Effexor, that can actually, for some women, be pretty helpful with some of those menopausal symptoms, even if you're not depressed. So once again, I think talking to your gynecologist or a menopause specialist about this, and they might be able to also help you find other non-hormonal treatment options.
Awesome. That's definitely good to know. And thinking about those non-hormonal things too, there's other things we can do. And probably even some non-pharmacologic things as well, non-medication things as well. Dr. Sarma, I wanted to come back to you if there are two things. One, if you wanted to kind of finish that discussion of kind of that multidisciplinary approach to things after SCAD, which reminded me kind of one of these questions on here that we received was, if hormones are related to SCAD, why does it affect the coronary arteries as opposed to all the arteries, or does it? What do we know about that?
So that's a great question. So we do know there is a lot of overlap between women who have spontaneous dissections as well as women who have evidence of extracoronary involvement. So I will say, and maybe I'll go back and share a little bit of what I had on here. Actually, I don't know if this comes up for you guys, but I sort of put this slide up here to sort of talk about what we do in sort of a systematic way. And one of it is we actually do extracoronary imaging on all of our women who have had a spontaneous dissection. So at our center, what we do is a CTA head to pelvis to look for an extracoronary arteriopathy, which is sort of a generalized term for an arteriopathy that may not meet strict criteria for fibromuscular dysplasia or fibromuscular dysplasia. So although our knowledge is still evolving with respect to this, we do think that probably, there's a lot of overlap, and it may not be that the vessels of the heart are unique to the heart, but rather, important to look at the entire body and make sure that we don't see evidence of arteriopathy or other areas that may be vulnerable to dissection. And we also tell our women who have had a spontaneous dissection about risk prevention methods for other dissections, particularly giving advice about, minimizing neck manipulations so that you reduce your risk of having carotid or vertebral dissections, for example. So I wouldn't say that it's necessarily unique to coronaries, although this is something that's still evolving. In terms of sort of other comprehensive evaluation after spontaneous dissections, after extracoronary imaging, we often will send women with either no evidence of FMD or some type of more nonspecific arteriopathy for consideration for cardiovascular genetic testing to look for some specific genetic conditions that are inheritable and that increase women's risk for having dissections, not just of the coronaries, but potentially of the aorta as well. And so there are a subset of women that will be identified as having one of these inheritable connective tissue disorders that may not have been picked up otherwise. So that's why we do that as well. We do recommend cardiac rehab to all women after a spontaneous dissection. This can be very helpful for thinking about how to get women back into regular exercise and feeling comfortable with doing that with some of the physical activity, guidance that we provide them. And then we also, as this group is so nicely demonstrating, know that it's really helpful to have some peer support surrounding this. So, connecting women with other SCAD survivors so that they don't feel like they've had something that's just happened to them. They know that there are other women out there who have gone through the same type of post-SCAD adjustment. And then, I think we've touched on most of the things here in terms of some of the long-term goals. So in the immediate sense, we're often managing symptoms of angina, which can often persist for a while after an initial dissection. We are also focused on making sure that you get on the meds to manage chest pain, and also central to that is beta blockers for trying to reduce your risk of having recurrent SCAD, controlling any hypertension that you may have as well. And then discussing things like reproductive counseling, birth control, discussing women's desire to think about pregnancy and what what individualized counseling might need to go into that. And so I just wanted to highlight that I think, as we've been saying here, it's really just not the cardiologist managing your SCAD by themselves. So I think this is a really important point that we've all emphasized. We involve our colleagues from vascular medicine to think about women's extracoronary disease. As we mentioned, cardiovascular genetics, we work very closely with OBGYN, MFM, to make sure that we're considering all those other factors. A lot of times women have a lot of anxiety and depression that also plays in. And so having support around that, I think, is really, really important for women. And so definitely a huge part of SCAD management. And then also, while I mentioned that we routinely refer women to cardiac rehab, we also have a cardiac performance program, because a lot of women have been engaging in higher levels of physical activity and probably need a more individualized exercise plan. So I think a lot of women who have been very highly active and do have a spontaneous dissection initially, that's one of their big concerns. So I think understanding that it's not just a cardiologist, but really a team-based approach to managing women after SCAD, and understanding what your goals are really important in order to understand how to best care for you long-term. I don't know if that answers some of the questions you initially posed.
Absolutely. So it sounds like it does. Like, it's not necessarily just coronary arteries, and that's a big part of why we need to have that multidisciplinary approach and have that cardiologist who looks at everything. You also mentioned chest pain, and the angina, and there was a question about that too. A patient mentioned, I have chest pain at the same time during my menstrual cycle each month. Why is that? Like, it's not in my head.
So I have to say that that is something that I do hear from women. I don't know that we have a clean answer to say that it's definitely hormonally related. And I think that chest pain after spontaneous dissection is also very complex, and it's also very common initially after a spontaneous dissection. Oftentimes, early on, when you also have an increased risk for having a spontaneous dissection, it can be sometimes hard to know, is a woman having a recurrent dissection, or are they having angina apart from that? There can be additional coronary spasm, microvascular dysfunction. All of these mechanisms can additionally play into, chest pain that occurs after SCAD. So I think one of the important things is sort of really figuring out when women are having angina, and also what are they responsive to, because not every woman responds to medications the same way. So I try to get a sense after I've known a woman for a little bit of time about what her triggers are for chest pain. And we figure out at those times, do you take an extra medication? Or, if we know that there are certain things that increase your blood pressure, do you take a medication before those certain activities to try to keep things as balanced as possible so you don't experience that chest pain? So I do think really sitting down with your cardiologist and providing as much detail as possible can be helpful to coming up with an individualized medication plan, and then trying different medications too. So I think we've talked about beta blockers as a mainstay, and there are a lot of different beta blockers, and sometimes one works for someone and another works for someone else, and it sometimes requires a little bit of trial and error and seeing what works for you.
Awesome, absolutely. And I love that point of just that reminder that chest pain can happen after SCAD too, and really working with your physician to figure out what's the best way to manage that, because I know it can be a scary symptom for people. Do you want to add, Dr. Naderi?
I was just gonna, one thing I think we haven't really mentioned is we've all had patients who've had their SCAD event during a first pregnancy that resulted in a miscarriage or a stillbirth. So I just want to acknowledge that I know that if there are any of you out there that fall into that category, that adds a whole different layer of complexity to this conversation, and that regardless of how nervous it makes us, because it's such an unknown for us to have our patients have pregnancies after a SCAD, whether it's associated with pregnancy or not, that we've all helped our patients develop a birth plan in a multidisciplinary approach to have pregnancies. The problem is that when I do preconception counseling with my MFM counterparts, and one of the beautiful things about COVID, the C word, is that we've actually been able to do a lot of virtual team meetings with our patients. So it's actually, I guess that's like a weird silver lining in like this total disaster of a year. And neither side can really quote you a risk. And I think that's the major problem we have. We sit down, I'm in California, I'm in San Francisco, a lot of my patients are in tech and they like data. And unfortunately, we don't have hard data where I can say you have 2 times higher risk or 4 times higher risk or 10 times or whatever. So we just know your risk is higher, but I can't quantify it for you. But that doesn't mean that it's an absolute contraindication, mainly because we all have case series of patients where the majority of patients do fine. The problem is these are spontaneous events, right? So there's no imaging I can do. There's no evaluation I can do to say there's some impending issue happening. It either happens and we have to have a birth plan, backup plan, how are we going to bail you out and keep you and baby safe plan, or it doesn't, we all count our blessings and we're so excited when the baby's born. And then as Dr. Lindley mentioned, you're not out of the woods after baby's born, right? Because most of our complications are happening in the 2 to 3 months postpartum. So it's a long, very challenging road. But I would say that all of us who do this every day try to help support our women to make whatever decision they're at peace with. And that it's very individualized, and that what you read on, one of my little pet peeves is when my patient says, well, someone posted on Facebook that they did it and it was fine. You have to realize that each of our patients have a different risk profile. So I think Dr. Economy might have mentioned, if your heart's weak after SCAD and it remains weak, it's a whole different ball game than if your heart muscle functions recovered. If you're the rare, heart transplant case we have carried heart transplants through pregnancy, but like that's a whole, you know, I'm talking about total extremes. So you have to keep in mind that while all of you have had a SCAD event, you're not all the same in terms of your risk for future pregnancy. And that's where the kind of intimate discussions with your local team come into play. So I just wanted to throw that out there.
Absolutely. Thank you. I really appreciate that. And that, you know, it really highlights that, you know, discussion that working through it with your provider. I have a couple others that are not related to pregnancy that I want to make sure we get to. Dr. Lindley, can I call on you? A question of is SCAD related to fluctuation in hormone, like inconsistent use of something like birth control pills, or do we know?
The long and short of it is we don't know.
Okay.
Yeah, that is something that's been postulated in the past, certainly related to the fact that, you know, it happens after pregnancy, and we've seen it happen around the time of menopause. But, you know, all of those findings are also pretty biased by the fact that lots of women go through menopause or have babies and don't have SCAD. So we really don't know the answer to that. Of course, consistency in taking your birth control pill is really important, because that's how you will keep from getting pregnant. But we really don't know if whether or not, you know, consistency or changing type of contraception really plays a role or not.
Okay, makes sense. Another one that's not related to that, but a little bit different, is somebody asked if there's a connection between breast cancer, like ER positive breast cancer, and SCAD. Do we, you know, we think about estrogen in that case too. Do we know?
I'm not aware of any relationship with that. I don't know if anyone else is aware of data, but I've not read anything about that.
No, I mean, it's a great question. It does make you wonder. But as of now, I think that's why the registries are currently so active, so that we can gather that information, but there's not a clear correlation, although I have had breast cancer survivors who've had SCAD, but like Dr. Lindley said, sometimes you don't know if they're just true unrelated or somehow associated.
Right, absolutely, good point. We can have multiple things that happen, and that doesn't necessarily mean
Yes.
Connected. A couple other, a little bit rapid fire, but if, you know, since we have a few minutes, I want to make sure we get to as many questions as possible. Is it safe to have a hysterectomy done, you know, 5-6 weeks after SCAD? You know, does it matter if they're, you know, removing just uterus, ovaries, and uterus? Anybody have opinions on that? Dr. Economy?
Sure. Yes. I think that, I mean, I guess the question is, why are you having a hysterectomy? I mean, so like the very short answer is, if you are medically stable, you have good cardiac function, there are very few emergency hysterectomies that we need to do. We predominantly do them as sort of semi-elective procedures. So you would want to make sure you're in the best cardiovascular health before undergoing any surgical procedure. But a hysterectomy is not a major surgical procedure, actually. And usually nowadays, we do most of them laparoscopically, so through very small incisions, and they can be same-day surgeries if you are cleared through your cardiologist for that. In terms of taking out the ovaries, I mean, that's a very different conversation, and that really does require a conversation about the difference between surgical menopause, which can actually be quite dramatic, and sort of menopause that you go through over time, which tends to be a little slower, and you can manage symptoms, I think, more easily. Surgical menopause can be very, can cause a real sudden onset of menopause symptoms that many women find more unpleasant. So I think those are some considerations, but no reason. The uterus itself is not an organ really of anything other than childbearing, really. And so you don't need it per se to perform other functions. It's not the heart, but it does grow a baby. It has some really important things it does.
Absolutely. Thank you, appreciate that. Yeah, so just to touch on one thing, just in general, and I'm chasing the sun here in my view, but the most questions were submitted in advance. So if we're trying to get to some that were submitted live too, But if we don't get to them, we will try to get answers to you, okay? So hang in there. I do want to ask, patient mentions being not knowing if they're menopausal, maybe that's because they're, using Mirena or some other thing. Do people need to know, from a cardiovascular standpoint, like that they have, begun menopause or any of these things?
I can answer that. I mean, so for most women who have a Mirena still ovulate and still produce, estrogen hormones. So it's really an extremely low level of progestin that's released from the IUD, and it mostly just affects the uterine lining. So, even though there is a significant portion of women who aren't having periods when they're on the Mirena, you certainly may still begin to develop menopausal symptoms when you start to go through menopause, even if you have the Mirena in place. So you might start to notice hot flashes and vaginal dryness and all those things, even if there's not been a change in your periods. I do think it's relevant to your cardiologist to know if you're going through menopause, maybe not specifically related to your SCAD, but just in terms of your overall cardiovascular risk. We know that around the time of menopause, blood pressure starts to go up, risk of diabetes goes up, cholesterol starts to go up. And so at least I personally start to screen women much more close together in terms of their other metabolic risk factors when they're going through that transition in their life, so that we can sort of aggressively treat those risk factors and prevent atherosclerotic type heart attacks, as well as preventing strokes.
Awesome, thank you. Kind of as a final question, and I think this ties into Dr. Sarma, you're talking about kind of follow up just even after SCAD, but it sounds like this is a lot of discussions, a lot of really, really great things that we need to talk to with our cardiologists, our gynecologists, PCPs, our primary care providers. Are those, and maybe everybody has an opinion on this, but are those things that typically are done, at like an annual appointment, or do you typically appreciate patients having a special appointment for some of these symptoms or things? What's the best way to handle that?
So I think that the question is more what's sort of the routine follow-up after SCAD. So I tend to follow women closely in the first year. And I will say from a practical standpoint, that's when women are really, trying to get on medications. Oftentimes they're having recurrent chest pain and we need to optimize their medications a little bit more closely. But then there usually comes to a point where we get things in a stable, that's the goal, to get everything sort of stable, do all of the other types of testing, get you through cardiac rehab, get you to feeling like you're starting to emerge from this event. And then usually I do think it's important, whether or not it's with a cardiologist closer to home, or if you continue to see a cardiologist at a, potentially a multidisciplinary center, to check in, make sure that you're still on the right dose of medications. As we talked about, in particular, hypertension can start to increase with age. And that's a really big risk factor that we like to keep in check for both recurrent SCAD as well as your overall cardiovascular health. And so I do think it's important to see a cardiologist, and for anyone who's had a heart attack, at least once a year, make sure that you're getting your routine screening, make sure that you're, even just for your overall atherosclerotic cardiovascular health, getting your lipids screened, making sure you're exercising regularly, maintaining a healthy weight, that we are screening for diabetes, checking your blood pressure. All of those things still have to happen. It's not just an initial period of time. It's a lifelong ensuring that we keep your blood vessels healthy.
Awesome, and we're so thankful for you guys, for all of you who see us as patients and take care of all those things. We are going to need to wrap up. We're already a little bit after 5. I wanted to give one kind of opportunity if anybody had something else, any of the 4 of you had something else you wanted to add or make sure we touched on before we close. Everybody's good.
I was asked to put in
yes,
an opinion on the COVID vaccine because that has nothing to do with pregnancy. But I know it's on the tip of everyone's minds. So you guys chime in too if you disagree, but we all generally feel like getting the vaccine is much lower risk than actually getting COVID, even in pregnancy. For what it's worth, I am 31 weeks pregnant and I've been vaccinated. I mean, I'm granted just the N of 1, and I'm advanced maternal age and, you know, have my own risk profile. So obviously that doesn't mean everyone should go out and get vaccinated, but that's my personal experience. And that's generally what has been recommended to me as a patient, and what I've been recommending to others is that I think the risk of actually getting COVID far outweighs the risks of the COVID vaccine. And we think that perhaps COVID causes a more dramatic response in pregnancy than outside of pregnancy. So, and I'll let everyone else chime in really quick because I know that's just something everyone's been asking.
Yeah, I agree with everything that Dr. Naderi said. And while it's generally recommended that the vaccine be offered to all pregnant women, I think it's also important to recognize that you're not the average pregnant woman. You know, women who have underlying cardiovascular risk factors, diabetes, other conditions like that are at higher risk of having severe COVID than very healthy pregnant women. So particularly in that case, I think that definitely the benefits of the vaccine outweigh the risk. And so certainly for all of my patients who, if they're seeing me, they have a cardiovascular condition, I am recommending that they receive the vaccine, whether they're pregnant or not pregnant.
Same. And actually, I would put to all of you that we now have data on thousands and thousands of pregnant women that was just published. They released the first wave of women who have successfully received the vaccine in pregnancy. And of course, it's shared decision making. You should talk to your obstetrician. There is some timing things around when you get your other vaccines in pregnancy that we have to be careful of, but we really have been strongly encouraging it. And I think we're going to see this data on, 50,000 women, in the next couple of years come out. I do think the verdict on COVID and pregnancy isn't entirely established. Most of our initial data comes from women hospitalized with COVID. So I think you can say that if you are hospitalized pregnant with COVID, you may have a more severe form of the disease. It's not clear if you have COVID and you are asymptomatic in your home and feel fine and sort of have an incidental screening test for it, that your risk is substantially higher. But you should definitely talk to your doctor if you are pregnant with COVID.
Awesome. Thank you guys. And thanks for touching on that. It's definitely a relevant topic right now. So I am going to wrap up. Want to be mindful of everyone's time. Thank you guys so much for joining us today. Thank you, panelists. This is so informative and empowering. And, I know personally for me, it's nice hearing that is a lot of discussion about this, and there's a lot of factors, that's reassuring that it's not just me not able to find information. And I'm so thankful for you all doing the research and seeing patients every day. So we're going to wrap up for today. A link to this recording will be on our social media pages and on YouTube, and emailed out to our listserv. So be sure to subscribe to that at scadalliance.org. And we will see you next month for our next topic and Ask the Experts. Thank you all.